Peace. What's going on? Check. Sound check. Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up in a new chapter. Peace, peace. All right. Whoa. We're getting up there. Chapter 27. Clinical Assessment of Venous Return. Hemodynamic measurements were originally utilized to aid in the care of patients with myocardial disease. Their primary application in respiratory care aid in optimizing venous return and cardiac output in patients requiring airway pressure therapy. The following discussion is not intended as a complete presentation of clinical hemodynamic monitoring. Rather, it presents reasonable rationale and guidelines for hemodynamic measurements in most patients receiving airway pressure therapy. Atrial pressure measurement. The atria are chambers with thin muscle walls and relatively low pressure. Atrial contraction has an insignificant effect on the mean pressure measurement. Thus, for clinical purposes, the atrial pressure may be considered the result of two major variants. 1. Blood volume within the chamber, and 2. Intrathoracic pressure compressing that volume. Assuming that intrathoracic pressure is normal and consistent, the major factor altering atrial pressure is atrial blood volume. Pressure volume relationship. The atria function as capacitance chambers and are continuous with the large capacitance veins within the thorax. Thus, pressure volume relationships in the atria are similar to those of the venous system, i.e., small pressure change. Volume changes below maximum capacitance result in relatively small pressure change. Volume changes approaching maximum capacitance result in relatively large pressure change. See figure 26.5, which we looked at in last chapter. Atrial pressure changes are not linear related to atrial volume changes. Volume flow relationship, bottom of page 405. Atrial volume will be determined by the relationship of blood flow into and out of the chamber. When inflow exceeds outflow, atrial volume increases. When outflow exceeds inflow, atrial volume decreases. Of course, such imbalances of flow are transient. A new inflow-outflow equilibrium state is rapidly achieved, but a changed atrial volume constitutes part of the new steady state. Peace, YouTube. Welcome. Peace. Welcome. Welcome to the YouTube live book reading. Happy Monday, everyone. All right. Page 406, and I will put the vocabulary in the description when it's finished uploading. Thank you for being in this peaceful part of YouTube where we read books and learn from masters. So, highest heart love. Page 406 at the top. Pressure flow relationship. Since atrial pressure is directly related to intra-atrial blood volume, low atrial pressure reflects decreased inflow potential in relation to outflow potential. However, high atrial pressure reflects increased inflow potential in relation to outflow potential. Myocardial inotropy, ventricular contractility status will be the main determinant of atrial outflow in the absence of atrioventricular valvular disease. For example, an acute negative inotropic state will result in increased ventricular and diastolic pressures, which will result in a transitly decreased atrial outflow. The new equilibrium state requires an increased intra-atrial volume and a higher atrial pressure. Obtaining atrial pressure measurements. Central venous pressure, or CVP monitor. Thank you so much. Peace, everyone. This is the peaceful, quiet part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Neville Riley. So thank you so much for being here and reading books with us. We go through the thick of it, right? Yeah. All right. I mean, we're in page 406 in the middle. Look how much we did. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading books with us. Central venous pressure is classically obtained from a catheter placed at the junction of the superior vena cava and right atrium and traditionally attached to the vertical water column device. Therefore, the common unit of measurement is centimeters H2O. The normal range for CVP is 5 to 15 centimeters H2O. However, the delta factor, i.e., delta PAT with volume loading, is the most significant measurement. Let's put a pin there. Ding! The most significant measurement. You see that? I'll read it again. However, the delta factor, i.e., delta PAT with volume loading, is the most significant measurement. A CVP measures right atrial pressures and therefore reflects the systemic venous return and right ventricular preload. In patients in whom it is reasonable to suspect that function of the left heart is as capable as the right heart, the CVP is a useful and valuable monitor. However, often in the very critically ill patient, the left heart is incapable of functioning similarly to the right heart. Such circumstances require the placement of a pulmonary artery catheter to properly monitor left ventricular preload. Pulmonary artery catheter. Peace. Oh my goodness. Janina manifest highest heart love. Thank you for being here. Meow. Oh wow. Mia Mia. Pulmonary artery catheter. The bottom of page 406. Development of the Swan-Ganz pulmonary artery, balloon-tipped catheter, has made catheterization of the right heart and pulmonary artery technically feasible and relatively safe to perform at the bedside of the patient in intensive care. The basic double channel catheter has a fluid channel, which opens at the distal tip, and a second air channel connected to the balloon located close to the end of the catheter. The balloon may be repeatedly inflated and deflated with small amounts of air. Top of page 407. Placement. The catheter can be introduced into the systemic venous system either by a surgical cut down over the antecubital fossa or the percutaneously via the subclavian, external or internal jugular veins. Occasionally, the femoral vein may be used. The catheter is advanced with the balloon deflated until it lies within the chest cavity. The balloon is then appropriately inflated and further advanced, allowing the blood to flow to carry the balloon tip in the manner similar to an embolus. In essence, the blood flow carries the tip of the catheter through the right ventricle and pulmonic valve into the pulmonary artery. Prior to introduction of the catheter, the fluid channel is filled with heparinized saline and connected to a pressure transducer, allowing instantaneous display of the various pressure patterns on an oscilloscope or cathode ray to projection on the phosphorescent screen. A continuous ECG recording is essential for careful monitoring during advancement of the catheter. It is not unusual for the catheter tip to cause a few ventricular premature contractions as it passes through the right ventricle. Occasionally, a severe ventricular arrhythmia will occur, necessitating immediate removal of the catheter from the right ventricle. The balloon should not be deflated with the tip of the catheter in the right ventricle. Very key. Oh my goodness. Thank you so much. YouTube, what's up? Peace, peace. Peace, Just. Hi, it's Heart Love. Oh man, it's so deep, right? Yeah, this is super high level. This is the peaceful part of YouTube, the intellectual part, reading medical books. So yeah, I will put the vocabulary in the description when I'm finished, just like I do with all the other books. And you can check it out from there in the playlist. Thank you so much for being here and reading with us. Love to all the book lovers community. Hi, it's Heart Love. All right. Pressure patterns. In the middle of page 407. Figure 27.1 illustrates the classic pressure patterns displayed as the catheter tip traverses the right atrium, right ventricle, and main pulmonary artery, and eventually lodges in a pulmonary artery branch in a wedge position. Wedge position. The catheter tip is positioned so that the inflated balloon completely occludes proximal blood flow through a branch of the pulmonary artery. When the balloon is deflated, there must be free flow of pulmonary artery blood around the tip of the catheter, and the pressure reading will represent the phasic, systolic, diastolic, pulmonary artery pressures. Inflation of the balloon should be kept to a minimum since blood flow to a significant portion of the lung is obstructed while the balloon is occluding the vessel. It is also possible for the tip of the catheter to advance, migrate outward after being initially positioned. In some circumstances, this can result in an occlusion of the arterial branch, even with the balloon deflated. This complication can be avoided by careful, continuous monitoring of the phasic pulmonary artery pressure pattern. When a dampered pressure reading is observed, the catheter channel should be vigorously irrigated and the integrity of the pressure transducers thoroughly evaluated. If the tracing is still dampened, the catheter must be retracted and repositioned until a satisfactory pulmonary artery pressure pattern is obtained. With the balloon properly inflated, the pressure reading just beyond the catheter tip will reflect back pressure through the pulmonary circulation. These wedge pressure readings, PWP, relate to the filling pressure of the left ventricle in a manner similar to the way central venous pressures readings relate to right ventricular filling pressures. With the balloon deflated and the catheter in proper position, pulmonary artery blood will be flowing past the tip of the catheter. Under these circumstances, a blood sample properly drawn through the fluid channel will have a true mixed venous oxygen tension and content. Excellent, excellent. All right, so this is figure 27-1. We're in a new chapter. Gotta love it, right? Oh my goodness. All right, so this is 27-1, and it's showing the cardiovascular monitoring system and of a heart in A, B, C, and D. All right, and it's the typical pressure patterns as the tip of the Swan-Ganz catheter traverses the right heart and pulmonary artery. So A is the right atrial pressure, B is right ventricular pressure, and note that the diastolic pressure is zero baseline or below. C is the pulmonary artery pressure. Note that the diastolic pressure is significantly above zero baseline. And D, pulmonary wedge pressure. Catheter tip senses only pulmonary capillary back pressure since balloon obstructs arterial flow. Deflation of the balloon should result in immediate return of the pulmonary artery pressure pattern. See text, which we just read. All right, so A, B, C, and D, as you see. Thank you so much for being here and reading with us. Hi, it's Heart Love. Clinical application of respiratory care, second edition by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yearbook Medical Publishers, 1979. Thank you so much. Oh my goodness. Much love. Yes. All the intellectuals. Yes, that's right. You'll just be able to click on it and just read through the entire book, right? I know. It makes people who's not that intelligent, yeah, it'll make your brain hurt. That's definitely the truth. That's okay. That's why it's YouTube, right? You have plenty of freedom, places to go where there's a bunch of other stuff being talked about or discussed. We read books and uplift the people here on this channel. This is the Loving Light Workers channel. So thank you so much. Feel free to sub and, hit the like. We appreciate all the book lovers community we're a part of. Thank you so much. All right. Pulmonary wedge pressure, or PWP. In the middle of page 409, we are the champions, definitely. This is not a direct left atrial pressure measurement. However, when the catheter tip is properly positioned, the pressures are very close approximations of left atrial pressures and delta factors correlate reliably. The normal range of PWP is 4 to 12 millimeters Hg. However, pressures up to 18 millimeters Hg are acceptable in critically ill patients. Thank you so much. Look at that love. Awesome. Yes. For all the aspiring nurses and MTechs and reps and, oh my goodness, all the nurses, we love you so much. Thank you so much. Gratitude. Optimizing venous return, the fluid challenge principle. Oh, this is so great. This is amazing. Middle of page 409. This is very key. So, taking notes, this is definitely where we want to zone in. A finite volume of fluid added to the vascular space in a given time period is referred to as a volume load. The difference between atrial pressure measured before and after a volume load is referred to as delta PAT. Relative hypovolemia exists whenever the vascular volume is insufficient to fill the existing vascular space. A model system has already been constructed, see figure 26.5, in which the minimum and maximum venous capacitances are predetermined. In figure 27.2, the model is modified to show the relationship between delta PAT and flow. In this schema, a state of relative hypovolemia exists below the point of minimal capacitance. This results in a low peripheral venous pressure, which leads to an inadequate venous driving pressure. Venous return is significantly diminished. In the circumstances depicted in figure 27.2, repeated volume loads will result in insignificant changes in atrial pressure, which is the A delta PAT, in area. A, as the vascular volume is increased, the relative hypovolemia is essentially reversed, so that an additional volume load in area B should produce a small change in the delta PAT. Further, volume loading now results in measurable atrial pressures changes with corresponding improvement in flow, area C. Right? At this time, increases in vascular volume are also resulting in increasing venous caliber, thereby improving conductance. As the point of maximum capacitance is approached, area D, larger changes in atrial pressures are observed with continued volume loading. When the maximum capacitance of the venous system is exceeded, area E, a state of relative hypervolemia, further volume loading will result in extremely large atrial pressure changes with minimal improvement in flow. In other words, at the point represented by area D, atrial venous return has been theoretically optimized. Yes, that's what we want. Therefore, continued inadequacies in cardiac output must be secondary to factors interfering either with atrial or ventricular outflow or to primary myocardial dysfunction. When atrial ventricular valvular disease exists, changes in atrial pressure measurements cannot be assumed to reliably indicate changes in outflow. Furthermore, in patients with chronic myocardial dysfunction much higher than normal, atrial pressures may be needed to optimize outflow. In most clinical circumstances, when a state of relative hypovolemia exists, the vascular space is significantly contracted, i.e., approaching minimal capacitance. Yeah. However, a state of relative hypovolemia can exist without increased venous tone. In general, early septic shock usually represents a state of relative hypovolemia in which venous volume was initially normal but becomes inadequate secondary to an abnormal reduction in venous time. All right, so here we go. This is figure 27-2. We started off a new chapter. Awesome. It's amazing. Yes. We are the champions of reading on YouTube. Definitely. No cap. All right, so 410, we have figure 27-2, a model depicting the theoretic relationship between venous flow and the change in atrial pressure resulting from a specific fluid load. So we just read this. Now look, the minimum capacitance is going to be all the way over here, and the maximum capacitance. At the top, you have the relative hypovolemia, relative normovolemia, and relative hypervolemia. Okay, so the hypovolemia, the normal, and the hyper. And as you see, maximum capacitance in D and E is where it's at for relative hypovolemia. It just shoots up. Thank you so much for reading medical books with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We get to see how all of this came about. We're just lifting up a whole generation, giving them the information as it came from the masters when they originally wrote it. And now we have so much great equipment that can actually, we see the beginnings of it, searching for solutions. And see, that's where we always win. We always win when we're going, oh, what happened before? Okay, how can I build on top of that? See, that's why history matters. So, from the beginning of this beautiful, peaceful YouTube, just been giving you factual information so you can put together the dots. When you put together the dots, you can project even forward where you're going. And that's helping the people. That's what this peaceful part of YouTube is for. All right. Page 411 at the top. The fluid challenge principle is a clinical means of assessing the adequacy of venous return and its interface with ventricular or preload function, as schematized in figure 27-2. Since pressure measurements are taken at only one point in the system, the atria, understanding the physiologic phenomena causing pressure changes is paramount to their proper clinical applications. We're going to pause right here. Top of page 411 in the new chapter, chapter 27, reading clinical application of respiratory care. We are in the 400s now. Woo! Shaking it up on YouTube, making the dummies' heads hurt. Woo! Live from the light. So peaceful. Love you. Every day we get better. Every day we heal. people. Thank you. So grateful and thankful for all I have now and all that is coming to me. So grateful. Let's have a glass of love water, right? Loving the people. Yes. That's what we do here. No nonsense. All great. Thank you so much. I love you. I love you. I love you. All the beautiful birthdays and solar returns we had last few days, families and friends. Beautiful, beautiful days and nights. When you live in the light, love you. Love you. I love you. I love you. I love you. Oh, that's so great. Thank you so much for being here, reading books. To all our friends and family. Highest heart love. Peace, peace. We will see you soon when we come to the next reading of chapter 27, live from the light. Peace, y'all. What's up? What's up? Live from LA. Time to go outside now, right? Yes, yes. One day, exactly. Heal the people. We have another year healing session coming up, right? It's absolutely amazing. So great. We shake it up on YouTube. I love you. I love you. And you know, I love myself. I want you to have a wonderful day. Remember, stay in the light, in the love frequency, right? High is five. Peace, peace. I'll see you soon.